Well, I hope our first two speakers have got us thinking, and because again, as I said earlier, we want the day to be an exchange of thinking and ideas. And so what we're moving on to now is our next session, where we've got 4 individuals who submitted an abstract of work that they've undertaken during one of these experiences overseas that we've heard a little bit about. And these were competitively judged, so these are the best of those submitted. We have 4 for you now, and we have 4 later on today. And so the format that we're following is what is called a 3-minute presentation, and that's a very strict way of presenting your ideas. Each presenter has 3 minutes, and we've given a little bit of flexibility to show we're all heart. They've got 3 minutes and 5 seconds just to make sure they can finish their sentence, to present a very succinct and concise summary of what they did and what they learned during their experience. And then we will have the opportunity again to ask them questions at the end. So we've got 4 of the finest. Their names are listed in the programme, but they're slightly different order. So first of all, we'll have Clare Logan. Then we've got a change to the programme. We'll have Jo Bourdillon-Schicker. Then we'll have Susannah Cochrane. And then we'll have Mark Gradwell. They're allowed up to 1 slide. So some have chosen to have the 1 slide, some have chosen not to. So it really is a strict format and has proved to be really successful. Jed just talking about evidence base. It's got a really good evidence base in terms of communication skills, and it's a very good discipline to learn to get your message across in this way. So we will begin. Just one final point, is there will be a prize at the end of the day. One of the 8 presentations will be judged as to have been in some way worthy of a prize. And okay, so we're delighted to invite Clare Logan, who is the first.
Hello everyone, my name's Clare Logan and I'm currently a core medical trainee doctor working up in Liverpool. I went away with IGH in 2014 to George in South Africa, and my project was improving the efficiency and experience in the emergency department in George, and I worked particularly with Mike Vonk and Anne Smith, who's the head of the department there. So this slide really was just to say, although the detail might be different, health systems across the world are faced with the challenge of reducing waiting times and improving patient satisfaction in A&E, and it's something that's very important to the public and also often quite high on the political agenda. For my project, I look at 3 particular areas, so reducing waiting times, firstly, and for that we did process mapping. I interviewed various people who worked in the department, but also patients who attended the department to try and identify opportunities to improve efficiency. We then formed an emergency department working committee to try and implement those changes. And we managed to reduce the median waiting time from arrival to triage by almost 40%, and the median waiting time from triage to assessment by a doctor by nearly 30%. The next area that we looked at was improving the patient experience in the department. So I interviewed lots of different patients to try and explore their ideas of how the department could be improved. And things that we then implemented, we created a children's waiting area in the department, and we created and implemented some new signage to try and improve people's knowledge of what to expect when they come to the department, but also what to expect in terms of waiting times. The other area that we looked at was at handover and how to improve handover between shifts. So we reviewed the whole handover process, and I interviewed lots of different staff to find out what they thought was important to include. And then we implemented something called the ABC of handover, which particularly included lots of organisational, kind of operational issues to try and improve planning for the next shift and allocation of resources for the following shift, and try and improve patient flow. the key things that I learned from the project was the importance of really engaging with every member of the department. I learned a lot of information from speaking to the security guards, for the clerks, the nurses, the doctors. Everyone had a very different perspective. And I think involving people in coming up with ideas and the kind of decision-making process made them more ready for change and implementing those changes. So thank you very much.
Hi, yeah, my name's Emma. I'm a public health and paediatric reg who does a lot of A&E work. I'm very impressed you managed to reduce weights by such significant percentages. I just wondered if you could tell us a bit about how you did that.
So we, as I said, we did process mapping, and I interviewed lots of different people to come up with ideas, and the key things that made a big difference were introducing a number system for when people arrived to try and make sure people were triaged in the correct order. And another big thing that made a big difference was people were initially waiting for their case notes before they were seen. So we decided that people's case notes would only be requested after they were seen and if the doctor felt that that was appropriate. We did lots of other smaller things as well. There were 2 triage rooms, but one of them wasn't particularly in use, and we tried to allocate more nurses to triaging people to ensure that people who were sick were kind of identified earlier on.
Thank you. Any other questions? Our next presenter is Joe Bourdillon-Schicker, who is going to tell us about his experiences in 3 minutes and 5 seconds. Thank you, Joe.
Hello, my name's Joe. I am currently a broad-based trainee down in Brighton, and I was placed in East London, South Africa last year. First off, who here is a clinician? Put your hands up. Keep your hands up if you've ever used an integrated care pathway or something of that nature. And keep your hands up again if you've actually found this makes your working lives easier, as well as making a significant impact on patient care. Wow, lucky people, more than I thought. Okay, so for anybody that doesn't know, an integrated care pathway, or ICP, is a document that guides, records, and monitors patient care. And it was our job to roll out this ICP across the hospitals in East London in order to improve stroke patient care. Those that didn't keep their hands up to the end might understand that this wasn't all plain sailing, as ICPs often, whilst good in practice, don't reach their full potential. South Africa has a double burden of disease. It is equally struck by conditions, non-communicable conditions such as stroke, and there are bigger problems as conditions such as HIV. Our supervisor, Dr. Stacey Rousseau, the consultant neurologist, had identified 3 key areas for improvement in stroke care. The first was to standardise the initial treatment of stroke patients. The second was to mobilise a multidisciplinary approach to stroke care. And the third was the need for a stroke database or health information system. And she hoped that this would solve all those problems. And it was down to our job to implement it. So we started off by engaging all the necessary parties, all the interested stakeholders, and conducting thorough process evaluations. We then proceeded to pilot it across both sites. Perhaps unsurprisingly, the first one was met with poor uptake and had variable completion rates. Undeterred, we then rolled it out a further 2 times, each time incorporating feedback and our evaluation findings into each new draft. This is a project that really benefited from an IGH partnership. I myself, with my experience of using ICPs as a junior doctor, knew all too well the pitfalls that ICPs can generally run into, and was able to incorporate essential compromises between, on one hand, the ideal, and the other hand, the functional. My fellow IGH volunteer, Charlotte, was a public health researcher and brought the necessary skills to monitor and evaluate each stage of the process. In return, we learnt from our South African colleagues and from each other. One key take-home message was that in order for a quality improvement intervention to really succeed, it's not only got to improve patient care, but it's also got to be acceptable to the health professionals and make their lives easier. And that even if the said intervention is perfect, behaviour change always takes time.
Tell us your biggest, the biggest hurdle that you faced and overcame.
So, I think people who have used ICPs will know that often they can be complicated and time intensive. and because of this, there was quite a lot of resistance from staff. It's also quite a new concept. We did, as you can see from this, there is quite a lot of information, and they did feel that there's quite a lot of duplication of information, so we did take that into account. So I think probably that was the main hurdle to overcome, and as it becomes normalised, hopefully it will really continue to flourish.
And biggest triumph?
Biggest triumph, it was an absolute pleasure to work with the multidisciplinary team. So all those who aren't clinicians will know that, or might not know that stroke requires a lot of different inputs from physiotherapists, nursing, occupational health therapists, and they were the ones that really got on board and really drove this forward. So working with those as our partners was really rewarding.
Wonderful, thank you very much indeed. Great, so third up is Susannah.
Thanks. So I'm Sue Cochrane. I'm a public health registrar from Wessex. And I went out to Cape Town 1 year ago, my third year of training. And when I arrived, I was presented with the problem that there were barriers to accessing appropriate timely care for patients referred from primary care. And this was articulated by family physicians. So the family physicians in primary care were basically saying they were referring patients up for non-urgent care, and these patients weren't receiving their appointments. And that was leading to an escalation of health issues. And I was basically asked to find out what was happening and to generate some recommendations. So as a public health registrar, the first thing I do is look for data and evidence. So I basically went to one primary care centre and input 420 referral letters from this primary care centre over 6 months. And I tracked time in the patient journey from primary to secondary to tertiary care and had a look at the times it was taking for the different steps in the process map. I then really focused on building relationships. So I spoke to as many people as I physically could, from admin staff to management to clinicians, and actually just tried to understand what the barriers were to the referral systems that were in place. And while having those conversations, I also tried to identify local best practice, of which there was a lot. So I identified local, national and international best practice, and basically went and spent time with the local best practice to understand how it could be replicated. And I then came up with this toolkit for change. So in essence, I took all the themes of the best practice that I'd identified and identified 4 main things that areas could do to improve their referral systems up from primary care. So the first was around demand management, so sorting referrals efficiently, prioritising urgent cases. The second was around communication, so having a system that allows both feed up and feedback, involves patients and clinicians, and very simply, actually having clinicians understand how they can refer and who they need to refer up. So another thing was coordination across disciplines, so making transitions of care smooth and reducing the time between diagnosis and treatment, and actually just enabling appropriate referrals. And I just found that administrative capacity is such a key thing. The administrative staff were the real cogs in the wheel that were going to make things work. So focusing on that staff base was really important. So what I did was to use all this learning and set up a steering group. And within this steering group, we defined the common goals around what success looked like, and then spoke about what we could do to move it forward across these 4 themes. And it was a really interesting project for me. I had a lot of learning, but I would really echo the first speaker in saying that the biggest piece of learning for me was how to involve everybody. Just go out and speak to as many people as physically possible and to take them along that journey. And actually, that data and evidence really did talk to the problem. There were lots of anecdotal evidence of problems in the system, but actually collecting that data and presenting it back to the stakeholders was really key. So that was
Thank you. So again, same questions I asked Joe. So biggest challenge, biggest triumph?
The biggest challenge was defining the problem. I think people were quite frustrated in Cape Town that this had been an issue that had been going on for a long time, and they had lots of ideas of what they wanted to do, particularly around getting a phone app to make an efficient referral, and actually no one had spent time defining the problem. So I spent a lot of time saying, that's lovely, that solution's great, but actually, do we have a clue what's going on? So that was kind of my job to scale it back, which was quite hard.
And triumph?
Triumph, I think, was around my learning, but also around the legacy that I left. So I left a steering group that was hopefully going to carry on afterwards. I left a South African public health registrar taking on my project, so it felt like it had legs, which was really nice.
Okay, so now we're on to the final of these first group of 4, and this is Mark Gradwell, who's elected to go without a slide. Over to you, sir.
I'm going to start a timer because I will go over. Good morning. My name is Mark Gradwell, and in 2014 I was lucky enough to be sent to Kisumu, the city of Kisumu in Western Kenya. That's buzzing. My 3-minute talk is titled Ambulance Services for Kisumu County. Rather ambitiously, I want to start with a little bit on Kenyan politics. And I know that time's short, so we'll jump straight in at 2010. In 2010, the Kenyan government undertook a rather ambitious devolution of their central government and passed a lot of power to the newly formed county governments. About the same time, not a totally new Kenyan constitution, but there were certain amendments made to the Kenyan constitution that said that every Kenyan had the right to access for emergency medical care. And then a subsection of that went on to say that the newly formed local county governments were specifically responsible for the delivery of ambulance services in their new local counties. And that's significant because it made the newly formed local ministers for health legally responsible for addressing the issue of ambulance services in their counties. So Dr. Elizabeth Agaja is the Minister for Health in Kisumu, and I found myself trembling before her as I am in front of you now. And she asked me to find out what she had in terms of ambulance services, what I thought was needed for Kisumu County, how much will it cost, Mark, and interestingly, should we outsource? I sort of took a deep breath. And the answers, what I found out is what follows now. Kisumu County is 2,500 square kilometres in size. It's got a population of 1.1 million people. 700,000 of those live in informal settlements. There are 7 major health facilities and 1 teaching hospital. As of March 2014, the county had 1 ambulance that met international standards, 7 other informal vehicles, and no formalised referral system. I undertook a huge stakeholder consultation, and cut a long story short, they said we'd like 7 ambulances on the road. I costed this system out, procurement and outfitting of vehicles, development and of a centralised emergency referral system, training enough people with sufficient expertise to staff a 24-hour rota, replacing of disposable items down to ampules of adrenaline in Kenyan shillings, US dollars from multiple suppliers. 20 seconds. Outsourcing came up a lot, and it was highly political, but actually if you compare a 10-year costing for internal development versus outsourcing, it's more expensive at the start, but you'll save yourself $101,000 over a 10-year period. 10 seconds. 6 months ago, I received an email saying that actually the Kenyan government in Kisumu had decided to outsource, but discussing that will take a further 3 minutes of my time.
Maybe I could ask you, could you tell us what you learned from the process?
Yes. I'll miss that bit out. So two NHS hot topics, I suppose. The first one is quality improvement, audit, usage of good data, and from credible sources. What I learned was actually you have to, if you're going to think about a large system such as ambulances, and you need to map it out, and you need to figure out where the people are, the population density, what the need is. And we're quite good at that in the NHS, but actually it's something that just didn't exist. I had made a Google map of all the different healthcare facilities and said, look, this is where your things are, and this is where the people live and stuff. So I think that was a massive learning. And then the other learning was that we go on about this a lot today, but it's a total culture change, and it's doing all this in a situation where your communication skills are pushed to the limit because everything's different.
Thank you.